Good late morning. My name is Jim Barry, and it's my pleasure to be here today. I've had an opportunity to be part of Rice 360 from almost the beginning. I'm a Rice grad. Rice 360 wasn't here when I came, but my daughter was one of the first graduates. She's now a transplant surgeon, so it's certainly my honor to help moderate this esteemed group of folks by introducing Ann Barnes, MD, MPH. Dr. Barnes is a physician and a native of Houston. She is currently president and CEO of Episcopal Health Foundation. The foundation serves the 41 counties of the Episcopal Diocese in Texas and is committed to the promotion of health for all Texans. Through grants, research, and investments, and congregational and community engagement, the foundation strives to advance the vision that all community members have a just and fair opportunity for health. So it's a perfect fit for the topics at hand. Prior to her current role, Ann served as a clinician, educator, and administrator in 2 large safety net healthcare systems in the Houston area. She is active on local and state level nonprofit boards. Welcome, Ann.
I know that the theme of the conference over the next 2 days is innovation, and it reminds me of a quote that I saw, and it's been attributed to several people. All of them have the first name of Albert, so we'll go with Albert Einstein. And you can put in the word innovation, creativity, or discovery, but it's about seeing what everyone else has seen and thinking what no one else has thought. And that quote is actually really comforting for me and grounds me for 2 reasons. One, it reminds me that I don't have to invent, or EHF doesn't have to invent something from scratch. It can be something that exists, but the puzzle pieces need to be put together in a different way. The other thing that it reminds me of, and this is important to EHF as well, is that the folks who see what everyone else has seen are the folks who are living in our communities and are being affected by disparities and barriers. And those are the folks we should listen to because they see best and they probably are going to solve best. And so I think that that is really critical to this type of work, innovative work, and it is a muscle that we continue to try to build through our foundation. Recently, we launched a new strategic framework, which we call Igniting Change. And one of the central themes of our strategic framework is understanding that we all experience health or don't experience health in large systems that are around us. And EHF has named 3 of those systems. One is health and healthcare services, so that's both clinical and non-clinical. Community, again, which is central, and then policy. And one thing that we probably have all experienced and we all know is that those big systems don't actually work together very well. There are clear walls between them, and so part of what we want to do with our resources is to break down those walls and help those systems work in a coordinated way to improve health. And 3 of the big Texas health problems that we are interested in addressing using this coordinated approach are central to the topics that you all are discussing: maternal health, diabetes prevention, and food and nutrition security, which you can recognize affects both the diabetes conversation and the maternal health conversation. I wanted to share with you a few things that I think fall into the creative category that EHF is doing. These are maybe not the most traditional approaches that you might see from a philanthropy or in this space, and I thought it would be useful for you all to hear and maybe stimulate some conversation in our Q&A time. So the first is alternative payment models. So one of the things we know is that there is a lot of need in the nonprofit sector to address non-medical drivers of health, but there isn't always money to do that and to maintain the services in those nonprofit spaces. Alternative payment model is trying to get those with deeper pockets, so health insurance companies, managed care organizations, to not just pay for benefits that we're used to, like medications or procedures, but to actually pay for those non-medical services that we know are going to be critical to health and well-being. So we've been doing some work in that space. The other place that we are trying to make a difference in a different way, and again, we're not experts here, but we are beginning to learn about impact investing or program-related investing. And so this is really thinking, how can we use the financial resources we have in a way that's different than just writing a check? Now, writing a check is nice, and certainly if you receive that check, you're happy. But what's a way that we can put money into something that will improve health outcomes or has the potential, and then recoup those dollars to be able to then grant them again or invest them again in the future? And so we've done this in a couple of ways. We've done a couple of equity investments, small startups that are connected to our areas of interest. We give them capital, just like, Shark Tank, you invest in them. And if they're successful, the money will come back to you to give again another day. The other way we've done this is through a loan program. And so you're able to give large sums up front, typically to organizations that are trying to build a revenue-generating program. And then they're able to pay you back. And again, you're not looking for huge returns. You're just looking to break even if possible so that you can give those dollars out again. And then the last thing I'll mention is being an outcome payer. So there was a federal program that sadly was shuttered, as many programs were, but the idea was to give money to a community to address a health issue, and if they could reduce the negative health outcome by a certain percent, then this program would actually pay them for the positive outcome. You let people figure out in their community how that's going to get done, and so you can imagine it's going to take healthcare and non-healthcare players to make it happen. Even though the government program was shuttered, we stayed committed to this group of people and are going to try it out. So over the next few years, if they reduce severe obstetrical complications, we will be paying for their success. Yep. So thank you again for being here. I look forward to my colleagues and what they share in the conversation that follows.
Thank you, Ann. That was great. One thing I didn't mention was that I got my MBA here and majored in finance, and the fact that you just mentioned the opportunity to have your money multiply and come back into the system is just fantastic. It really got me thinking. Please welcome Katie Butterwick. In September of 24, the Cullen Trust for Healthcare welcomed the first executive director, Katie. Prior to joining CTHC, Katie served as Vice President of Strategy at the Hackett Center for Mental Health and as a Senior Program Officer in the Grants Division of the Episcopal Health Foundation. Her areas of expertise include early relational health, health systems, behavioral health, and reproductive health, including equitable upstream prevention approaches. She brings 25 years of experience in the nonprofit arena where she's worked in operations, communications, program management, fundraising, and leadership development. Katie is a native Houstonian and a graduate of Bel Air High School. She received her bachelor's and master's degree in art history, including the Murchison Scholar at Trinity University in San Antonio, and as a Rotary International Scholar at the University of Edinburgh and at Edinburgh, Scotland. Welcome, Katie.
Thank you, Jim. It's great to be here. I really appreciate all the time and the attention that you're giving to this really important and exciting opportunity. And thank you to Rice 360 for convening us all. Ann and I were just talking not long ago about that power of convening. And we were sort of in a space of thinking differently about things that everybody is seeing in common, right? And I think as philanthropy, we're still coming to terms with what our role is in this new reality. So I think if I can, I will name that we are in a period of unprecedented uncertainty and chaos, and particularly when it comes to how we fund the good work that we know is so important to do. I also want to name that I know the families that we try to serve, and those who are low resource in the greater Houston region, they're stressed, y'all. And our workforce is stressed. And when I talk to our grantees who stretch across the continuum of care from our major nonprofit hospitals all the way down to our standalone behavioral health and community primary care clinics, those are the things that come back to me. They're scared, they're stressed, they're uncertain, and they're looking for support. So in a time of emotional chaos, we might consider what opportunity exists there when we look at innovation as mission-driven disruption and compassionate care for one another. So innovation can sometimes just be listening, and I think it doesn't sound like a revolutionary concept, but it is relatively new in the space of philanthropy and even in nonprofits in general in the United States, to actually listen to the people most affected by the work you're trying to do, even before you design the work. And when you look at what impact is, what do those people who you wish to affect say the impact was, right? Like, these concepts seem like they should be like living and breathing in a capitalist society where market research has been something we've done from the beginning of time, but they are not usual in the nonprofit sector. And so that's innovation in and of itself, to set a table, to listen deeply, and to act on what you hear. I think from where I sit, the Cullen Trust for Healthcare is a smallish institution. We put about $5.5 million into this huge system every year in the form of grants to about 30 grantees. And I was looking through my list because we have a board meeting in 2 weeks. We have about 30% turnover in our executive directors' positions within those organizations. So there's a lot of change in leadership as well. And I know I got caught just the tail end of the previous panel, and there was some reference to this sort of building your own and how do you build this base and where do you get people from. I think we have to reimagine who has the right answers. We have to reimagine what the workforce of tomorrow is going to look like when it comes to healthcare. We're very interested in community-based professionals, those who are our community health workers, our doulas, our recovery support specialists, folks who can have a bilateral impact when they come onto the scene, right? They are of community, they experience increased opportunity to build trust with the folks they're trying to serve, and they also can raise their own economic mobility, right, if they're given a position for which they are actually reasonably and equitably compensated. So it's a practice that actually shows a lot of evidence, and it's been used extensively internationally. Here in the United States, it's been hit and miss. Thanks to the good work of EHF and others that we have we have an opportunity before us to actually bill for doula services and CHW services provided to women in the prenatal period. That's huge, y'all. We got to activate that. So understanding kind of the space that we're in and the new opportunities that are coming, right? Again, this listening carefully and this thinking collectively is really, really important. And it is a great joy and a privilege to sit in the place where I do, where I get to hear the wonderful work that's happening in the field. And I consider it also a responsibility to be attuned to the needs of those individuals as people, right? The folks who are doing this work are tired. They're tired. And so I see a lot of youth in this room, and I am grateful for it because you are going to be asked to step up and step out in ways that you probably never even imagined. But the fact that you are here is really, really, really important, and thank you. And I'm so happy to pass on the mic. But I'm going to give it back to you, Jim.
Okay. Thanks, Katie. Thanks so much. Our next panelist is Ruth Rakis. Ruth is Chief Prevention Officer for Cancer Prevention and research for the Cancer Prevention and Research Institute of Texas, CPRIT, where she leads the prevention program, which fosters collaboration and funds evidence-based interventions aimed at reducing the cancer burden across the state. Since its inception, the CPRIT prevention program has supported 11 million prevention services, reaching all 254 counties in Texas. Prior from joining CPRIT, Rakes served as the executive director for the Cancer Prevention and Control Platform at University of Texas MD Anderson Cancer Center. In this role, Rakes established and led initiatives with her team focused on place-based investments, health system strengthening, and impact evaluation, which aim to reduce cancer incidence and improve health outcomes at the population level. Prior to joining MD Anderson, she was the vice president of mission and strategy for the Livestrong Foundation, where she worked on all mission-related initiatives, including establishing and leading the Office of Evaluation and Research. She holds a PhD in educational psychology from UT Austin and has authored numerous publication reports and has spoken at scientific and lay audiences on topics such as community engagement, program evaluation, and cancer prevention and survivorship, as well as our own experience as a 30-plus year cancer survivor. Welcome, Ruth.
Thank you so much. Thank you so much for having me here. It's always like a little awkward after you get introduced. So my name's Ruth. It's great to be here with all of you. And I am the Chief Prevention Officer for the Cancer Prevention and Research Institute of Texas, which we lovingly call CPRIT. I know some of you from my last 9 years here in Houston, so I'm on week 4. This is the start of week 4 in my role at CPRIT. So you'll bear with me, hopefully, as I use my notes maybe a little more than I ordinarily would, and do my best to answer all of your questions. But it's so great to be here with all of you today. So many of you may already know cancer is the leading cause of death for adults under the age of 85 here in Texas, and it's also one of the leading causes of death from disease for children and adolescents in the state of Texas. And beyond the cost of human life, in Texas we spend about $59.5 billion per year in direct medical cost related to cancer, cancer morbidity, things of that nature. So Texas did something really innovative back in 2007 and voters overwhelmingly decided to pass a constitutional amendment. So we're in the time, voting, very important. So made a big decision to vote overwhelmingly to support the creation of CPRIT. And that was a $3 billion investment in cancer prevention, cancer research, and finding cures. And then again, in 2019, voters decided again to reinvest another $3 billion in CPRIT to continue this work. And that helps us to carry out our mission, which I do not have committed to memory just yet, but I will in like another week. Expedite innovation in research and in breakthroughs in cancer prevention and cures. Create and expand the life science infrastructure in Texas and create high-quality jobs, and invest in the research prowess of Texas institutions. So kind of along the lines of what we've just been talking, beyond funding, how do we really create infrastructure in Texas? Invest in people, in researchers, in programs, in places where research can get done in different and new ways. And so thank you, Texas voters. We're crushing it. So great job. So since the inception, CPRIT has funded nearly $4 billion for cancer prevention, research, and product development. Largely that goes to research awards, but it also supports product development. And then of those grants, $3.9 billion has been brought back into the state through new grants and new developments through those researchers that were already funded with that $4 billion, now bringing money back into the state. 23 companies have also relocated to Texas from other states, other countries, again, building that research prowess of Texas. So you know how in Texas we like to be biggest and best. Well, we're this great job. We're really doing a great job with making that happen. And one of the other very innovative things that CPRIT did from its inception, and I actually was in the room when they were making the legislative decision to put this on the ballot. So I feel like this is a baby I've seen grow up, and it's doing such a great job. So proud and just glad to now be officially on the team now. But one of the really innovative things that was decided to do is that research is sometimes pretty far down the road. And so what can we do for Texans right now? And so it's $3 billion over a 10-year period of time. So that's $300 million per year being invested back in Texas. And 10% of that is actually in the statute that it has to be invested in cancer prevention specifically. So that's the program that I get to oversee. So over that time, it's been $407 million directly in cancer prevention to 58 different institutions, organizations, community-based organizations here are really focused on preventing and reducing cancer risk, detecting it early, mitigating cancer effects through the delivery of evidence-based interventions. As you may already be aware, but certainly blows me away every time I think about it, 40% of cancers are associated with modifiable risk factors. So tobacco use, overexposure to the sun, and there are known, very good evidence-based interventions right now to get put into place to make sure everyone can reduce their risk for cancer. But if you live in an under-resourced community, you may not have access to those resources. And we certainly are not delivering those resources equitably across the state. So we know that there are evidence-based interventions. We know there are things that can be done. We know that people are experiencing cancer. But that gap between what we know and what we do is often quite large. And so one of the things we can do is fund those evidence-based interventions, bringing them out into communities, and then bringing people together to talk about them, back to that line of community coalition building. So making sure we're sharing those great ideas and bringing people together. So that's where we focus a lot of our time and attention, delivered 11 million cancer prevention services. There are more than 54,000 cancers and precursors that have been detected through those grants. More than 450,000 individuals received their first cancer screening as a result of a CPRIT-funded grant, which I think is pretty remarkable. And for every $30 in treatment cost, $30 in treatment costs are avoided for every $1 spent in prevention. And that really is I think a bigger picture idea here too, is really that idea of how do we mitigate these things before they happen. I am so incredibly grateful for the treatment that saved my life 30 years ago, but I still experience in late effects now, cardiac late effects, thyroid late effects. So many things, fear of a new cancer coming along, which is very likely for cancer survivors. And there are a whole lot of us cancer survivors in the state of Texas. So while I'm incredibly grateful for everything that has been done to save my life, it would have been super duper if I didn't have to have it in the first place. And we don't know about prevention for Hodgkin's just yet, but we're getting there. And the more space we can make for innovation, I think is really an amazing thing. So we do this at CPRIT through funding generally 2 grant cycles each year. We're in the middle of one right now, and they focus on 3 areas: cancer screening and early detection, the primary prevention of cancer, and then dissemination of existing funded evidence-based interventions through the CPRIT program. November 19th, we'll be announcing those 3, and typically we do a second cycle. We won't this year just because there was so much good science that came in the first time. We got nearly double the applications. But if you take a look next February, we'll have a new call then. Our partners in academic research, our colleagues in academic research, they do have an open cycle and they have grants that are open December 2nd. And I'm happy to do my best to answer questions about that during the question and answer as well. CPRIT has the most rigorous process I have ever seen for grant review in my life. So there are multiple different steps. They are reviewed by people from out of state. They are looking to see, are you innovating? Are you using the resources in the state that'll have the most impact? Are you measuring your outcomes? Are you aligning yourself to the Texas Cancer Plan, which is our state plan for how to do work best together, and that has specific activities that anyone can do to carry their work out. So I encourage you to take a look at that at texascancerplan.org. It's time. Now I'm already forgetting my acronyms. So I really would love for you all to come. And also just wanted to mention briefly that we'll have a conference about a year from now that is called Innovations. And so would love to have you all come to Galveston with us and learn more about that as well, too. So look forward to hearing your questions and answering more. Thank you.
Thanks, Ruth. That was awesome. Again, my finance mind loves 30-for-1 returns. That's great. Monica, welcome. Monica Williams, PhD, is a seasoned higher education leader with a strong background in partnerships and fundraising. She became the first president of Texas Women's University Houston campus in August of last year. As president, Williams provides strategic leadership for TWU's Houston campus located in the medical center across the street, which encompasses more than 60 medical institutions. Williams served 9 years as foundation president and vice president of advancement in the University of North Texas Dallas, and has held leadership positions in fundraising in the U.S. States Fund for UNICEF, Houston Works, Rice University, Prairie View A&M University, and Texas Southern University. She has an extraordinary record of achievement in leading philanthropic efforts, securing grants, and stewarding gifts. She has close relationships with Houston stakeholders that she formed in business, industry, nonprofit, and civic centers. She's also taught English in the Houston Independent School District and worked at Sylvan Learning Systems, leading its community-based programming. In addition to her lengthy record of fundraising and establishing partnerships, Williams serves as an adjunct faculty member at UT Dallas and at Texas Southern. She earned a bachelor's degree in journalism and English and a master's degree in communications at Texas Southern and a PhD in educational leadership at Prairie View A&M. Monica, welcome.
Thank you so much. Thank you. Thanks, everyone. I don't know how to follow such wonderful comments by my colleagues, but just to share a little bit, being a native Houstonian and an unwed teen pregnant mom at the age of 18, not knowing anything about health disparities, I can tell you that I was saturated right in the middle of every risk that there was, not because of my household income or because of where I lived, because I lived in a great community with a lot of resources, and my grandmother, who was ABD and was born in the late 1800s, there was something pioneering in her spirit, similar to TW and the pioneers that we are, that led her to a career in agriculture. And ultimately, she was what was called the county extension agent, and the first African-American county extension agent in Fort Bend County. And I would follow her around as a young girl, going into homes and teaching families in rural communities, which we're surrounded vastly by, Richmond, Rosenberg, all the way up to Kennelton, Mahia, little towns like that, to help families produce their own gardens and also help them to learn how to operate with electricity, new appliances. Like in my home, we didn't have a washer or dryer until I was about 15 years old. We had a clothesline, and we did have running water, but it was more like a rural community just up the road, not even 7 miles from here, next to Butler Stadium, if you know where that is. And so I'm reminded, just because of my own personal experience, that that the resources, having innovation and resources is so critical. I think it sort of led me to my career in social services and subsequently thereafter into higher education. But it started in the classroom teaching kids English, and I learned right then that there was in the inner city huge disparity and inequity, and I start trying to fix those children in their homes, and realized that the easiest way in which to do that was to partner with organizations that could make investments in changing communities. And so I learned that at Neighborhood Centers, Inc., where that's now called Baker Ripley, but I was on the leadership team at NCI very early on, and actually helped to design the Baker Ripley, what we now know as the Community Center, and is now the name of the organization. And so that was a vision 30 years ago when we were challenged by our CEO to come up with ways that you could innovate and change communities. And we had to go to philanthropists who would invest in those ideas and bring them to bear. And so the Ripley campus in the East End was my baby, along with 5 other community centers where we would provide wraparound services to families and go out and identify individuals and corporations and philanthropists to invest in those. I think it's sort of come full circle that my mom, who was a nursing student at TWU in Denton, met my father, who was on a date with another lady, and he sent the lady home in a taxi, and he and my mom were married 6 weeks after that, and so I interrupted the whole process of the TWU nurse, but I'm now the inaugural president at the institution across the street, and I just am reminded that the zip codes, the tale of 2 zip codes, 77004 and 77081, which is where the Baker Ripley Community Center is, that just right here in the same city, the needs are so diverse and the issues are so diverse. And so there's opportunity for us at TWU Houston to create and produce professionals who can change the narrative in those communities. And so I'm very inspired by that. Equally, if I think of the global lens, working at the U.S. Fund for UNICEF and traveling the globe with UNICEF, I was definitely inspired to have a clearer understanding about the diverse needs and how we could make a big difference with little initiatives like clean water and making sure that moms had healthy diets to be able to change their communities. And so I think the final thing I would say is 77030. When I was preparing for this panel today, I was reminded that the largest medical center in the world is right here, yet there are so many deserts right around us. And so that, too, is opportunity for us to make change. So thank you for inviting me.
Great to have you. Thanks so much. We do have some time for questions, if anyone wants to step up to a mic. In the interim, I'll sort of kick it off with Ruth. Preventing cancer is really, really important. What sort of new things are you seeing these days? And what, you know, when you think in the future, 2 years from now, 5 years from now, what might cancer prevention look like in your view?
Yeah, it's exciting to think about for sure. You know, I think one big thing is thinking across diseases, right? So many of the risk factors, most of the risk factors that we know are associated with cancer, for those that are associated with modified disease, are also associated with heart disease and diabetes and lung disease and many other things. And so I think thinking about how we're addressing health together, there are limited resources, there are limited people that can do this work, there are limited healthcare providers that can provide access. So I get excited about us thinking about how we're creating healthier communities and and creating infrastructure that can support those types of things. And I think too, we know so much that we don't, equitably share. And so thinking about how do you put people in a room together to really get those ideas across and make sure that we're innovating and sharing and making sure that people aren't recreating things that have already been done. There's things like the community guide where they spend so much time and effort really cataloging great public health interventions on a number of different topics. So when you're thinking of that next idea, take a look there and see, you know, are you building on something that's already been done, or or is there something that's insufficient evidence there that you might take a look at as well? There's also interesting things happening that are looking at blood tests. I think are ways out on those in cancer prevention, but there's some of those things that are happening. And I actually just went to a panel on our product development work, and I'm definitely not going to try and describe it to you accurately, but basically they were taking a rare earth element and magnetizing it, and you end up getting an element that can then treat prostate cancer. And so, like magnets and rocks treating prostate cancer, right? Like that's innovation. So beyond my scope for sure, but there are so many things, and I think we've seen so much progress. It's been really amazing. So look forward to 2 years from now.
Thanks. So we have a couple of questions. We got a few minutes.
Great.
I don't know which one of you was first.
Oh, thanks.
Go ahead.
So Lisa Hirschhorn from Northwestern University. So thank you all. This is like really inspiring. Ann Barnes, I was really excited and intrigued that you were willing to fund things which have outcomes which are years away. And so I guess the question I have is, what advice do you have for some of us who might be talking to funders about how to have that patience, and also how to, and this reflects some of the other comments, to really value what the community wants and how the community defines success as opposed to the donor?
Yeah, public health and the work that we're all engaged in is such a long time horizon prospect. I think slowly but surely people are starting to appreciate it. I believe, though, that given the nature of how we want things immediately, we have to be creative in finding some of those interim markers of progress. It's not always easy. But I think we have to be creative in trying to identify those so people feel like, okay, they're moving in the right direction. Prevention and return on investment for prevention does take a long time. It took us decades, centuries to get to where we are today. It's going to take probably the same amount of time to get on the other side of this, where we are preventing cancer, we're preventing poor maternal outcomes, we're preventing diabetes as well. And then the second part of your question was?
How do we convince donors to value what the community defines as success? I was just involved in a very large project, not NEST 360, where we actually were able to show uptake of very important, what we call evidence-based interventions, but actually did not drop under 5 mortality. And so it was viewed by the donor as a bit of a failure, but actually from a public health perspective was actually successful.
I would say that there is a movement in the philanthropic space, particularly in the health philanthropy space, to understand and hear from communities affected and to co-create interventions and to identify what's important to community members. There is a general acceptance that that is critical for the work, and innovation starts in the community with the person saying, you know what, this is annoying, and I think I know what I can do to fix it. That's where that voice is, and so there's an appreciation that we have to go there. And so, yes, it's late coming, but I think it finally has arrived, and I think as you engage with funders, you're going to see more of that being important.
Thank you.
Mm-hmm.
Got time for one more.
Hi, thank you all for the insights you all shared. My name's Alec. I'm a postbac fellow at Rice 360, and I have a question for Dr. Ruth. There's an awful lot of innovation in like cancer therapies, and I was just wondering if, or like how you decide to allocate money towards funding biomedical research versus funding more clinical public health interventions?
Yeah, it's a good question. So the statute for CPRIT has some ways that some of that is set up. So there's 3 funding mechanisms. One's academic research, one is product development, and then one is prevention. And prevention is really where the dissemination sort of work is being done, and so that's 10%. There's no sort of changing that unless the statute was to change. And then there's multiple different RFAs within product development, within academic research that people can apply to. And then again, it's the most rigorous the process I've ever seen for peer review that happens. And so within each one of those areas, sort of depending on how much funding is asked for, how many applications are coming in, there's decisions being made across each one of those things. And then each of our programs also has an advisory council that is constantly looking at what is happening, what is going on, and where are the highest priorities. In Texas, a lot of that times we're looking at things like rural areas and making sure that we're doing more in that space too. There's also a program called TREC that is making sure that those institutions that are not just in Houston, Dallas, and Austin are getting resources as well too. So there's a variety of different things sort of in place to take a look at that, because there is so much happening within the space of innovation in the sort of the biomedical space. So lots of things underway, and I'm happy to talk with you about it more as well.
Thank you.
Anne, Katie, Ruth, and Monica, thanks so much. It's been really great, a fantastic experience, and thank you for your time.